Hello students, let's discuss some of the MCQs which are related to the subject of pediatrics which were asked in the NEET PG 2021. So moving on to the first question, a case of rickets not corrected by giving cholecalciferol. On examination, the phosphate level is low, serum calcium is normal with normal parathormone and the diagnosis is being asked. The question can be the same or it can be related to the same language. Now, if you see here, this is a question of the refractory rickets. It's a question of the refractory rickets, and refractory rickets does not mean that it cannot be corrected at all. The refractory rickets means it cannot be corrected by giving cholecalciferol. So this is something a therapeutic diagnosis. The rickets which cannot be corrected by giving cholecalciferol, that is the refractory rickets. And when you consider the refractory rickets particularly here, there is one with the increased PTH level, another is with the normal PTH level and normal serum phosphorus, third is the normal PTH and there is the decreased serum phosphorus. Now, if you consider first increased PTH, this includes is the VDDR1A and 1B, VDDR2A and 2B, and this includes chronic renal failure. Normal PTH, normal serum phosphorus includes distal renal tubular acidosis, because in distal renal tubular acidosis there is acidosis and there is release of calcium from the bones which acts as a buffer. So basically what is present here is the demineralization. Basically here is the demineralization. And the third cause, normal PTH with decreased serum phosphorus, particularly two important causes. One is the proximal renal tubular acidosis, which also includes is the Fanconi syndrome, and second is there is increased amount of fibroblast growth factor 23, and this increased amount of fibroblast growth factor 23 can be seen in number of conditions, can be seen in the McCune-Albright syndrome, it can be seen in the certain tumors, for example fibroma and hemangioperitocytoma, and it can be seen in the hypophosphatemic rickets. Hypophosphatemic rickets, right? So this is basically what I teach in every class regarding the refractory rickets. So if I just apply this principle to the question being asked here, what we are saying is a case of rickets which is not corrected by giving the cholecalciferol. On examination, there is low phosphate level and there is normal PTH. So if you see here, if you go here, it is normal PTH and decreased serum phosphorus, right? So what it rules out, vitamin D dependent rickets, here always there will be increased PTH. Hypoparathyroidism cannot be the cause because normal PTH is being given. Distal renal tubular acidosis, there is normal PTH and there is normal serum phosphorus. So the right answer to this question is the hypophosphatemic rickets. The right answer is the hypophosphatemic rickets. Moving on to the question number 2, contraindicated vaccine in 3 months old with recurrent respiratory illness. Now, if there is a recurrent respiratory illness, most likely this indicates immunoglobulin deficiency. This typically indicates is the immunoglobulin deficiency because the word here is the recurrent. So that is the one thing according to the students, the age group given was 3 months. So there is recurrent respiratory illness, mostly immunoglobulin deficiency, which includes is the Bruton's disease, which includes is the common variable immunodeficiency, which includes IgA deficiency, and which includes IgG subclass deficiency. So mostly it is one of these conditions where it is there. Now this table I have taken from the Nelson, that is page number 1361. Here they write is the specific immunodeficiency and what are the contraindicated vaccines. If you see severe antibody deficiency, maybe X-linked E-gamma globulinemia or Bruton, and common variable immunodeficiency, what we say? Oral polio vaccine, smallpox, live attenuated influenza virus, BCG, yellow fever and live bacteria vaccines. All these are contraindicated and there is no data for the rotavirus. And if less severe antibody deficiencies, which includes selective IgA deficiency and IgG subclass deficiency, it is oral polio, BCG, yellow fever, other live vaccines appears to be safe. Other live vaccines, particularly here, we say you can give live attenuated influenza vaccine, that appears to be safe here particularly. So if I apply this to the question which has been asked here, it is not mentioned whether it is severe immunodeficiency or less severe, but if you see in both of them, the common thing which we can take is the BCG. The common thing which we can take is the BCG here. So if you see particularly here, inactivated polio can very well be given. Measles. Now this measles at 3 months of age, if it is given, it is not an indication. Moreover, why they have given measles? If there is immunoglobulin deficiency, you are giving is intravenous immunoglobulins. And if you are giving intravenous immunoglobulins, then particularly mumps, measles, rubella and varicella vaccines are not to be given. They are not to be given, right? So then DPT, it can very well be given. So the only two confusions, BCG and measles here, but as the table says, so I think the best and most appropriate answer here should be BCG, contraindicated vaccine in a 3-month-old with recurrent respiratory illness. That is most likely here answer BCG. In a child, height for age is less than -2 standard deviation. Now simple question, we all know basically weight for height is a marker of particularly acute malnutrition. Height for age, that is particularly a marker of chronic malnutrition. And weight for age is a marker of both acute and chronic malnutrition. Weight for height is something which you also call as wasting, and height for age is something which you also call as stunting, right? So there should be no confusion here. Height for age, if it is less than -2 standard deviation, it is most likely a case of chronic malnutrition. It is most likely due to chronic malnutrition. Now simple, always also remember one more thing. What do you mean by acute malnutrition? That is malnutrition for less than 3 months. That is for less than 3 months. So acute and the recent infection, they both will affect basically the weight for height. Again a question, according to the students, it was given 16-month-old boy, 8 kg weight, and there was a picture of the growth chart, right? So if it is being given weight for age, this is the growth chart we'll be using particularly, and you are saying is 16 months, so therefore it comes out to be here 16 months. And if I consider the weight to be the 8 kgs, 1, 2, 3, 4, 5, 6, 7, so we are saying is age here 1, 2, 3, 4, this is 5, 6, 7, 8. So 8 I take here, I go here like this particularly, here I take is the 8, so this comes out to be the point, it is less than the 3rd percentile. But some students were saying to me, sir, when we calculated on the graph, it was between -2 to -3, right? So if I take the girls chart particularly, if I take the girls chart here, here it is the 16, here it is the 8, so if I extend 8 here like this, and this particularly goes, then it is between the 2nd and the 3rd percentile if it is particularly given a girls chart, right? Now how to interpret this question, the right growth chart you people must be knowing because you have given the exam. Now if it is more than or this less than -3 Z score, you call it to be a severe malnutrition. And if it is -2 to -2.99, that is moderate malnutrition. And if it is -1 to -1.19, it is mild malnutrition. So if it was being given, according to them, the two choices were also related to severe. One, severe malnutrition, counsel mother on feeding. Severe malnutrition, referred to nutritional rehabilitation center. Now, if it was being given between -2 to -3, then your answer should have been moderate malnutrition. Moderate malnutrition. But According to the growth chart, if it is being given boy and if I calculate that is less than -3, then the answer should be severe malnutrition, referred to the nutritional rehabilitation center. Right answer, you must be particularly have given the exam, you can judge what was exactly being asked, but this thing you need to remember always. I always told in my class that more than severe, what is also important is mild and moderate malnutrition, because they are something which can be definitely asked, right? So therefore, most likely if it was -2 to -3 according to the many students, then your answer should be moderate malnutrition and counsel the mother on the feeding. Right? Then the child presents with the myoclonus jerks and decreased performance in the school. There is history of fever at the age of 1 year with rash. Fever with rash, which of the following investigations will lead to diagnosis? History of fever with rash around the age of 1 year. Most likely we are saying it is a case of measles at that time, and the child is now presenting with the subacute sclerosing panencephalitis. Subacute sclerosing panencephalitis, right? So that is the picture, subacute sclerosing panencephalitis. How to particularly make the diagnosis we talk here. Now to make the diagnosis of SSPE, what we say here is in CSF, elevated IgG and IgM antibodies in dilution of 1:8. That is 1. And in EEG, myoclonic phase, that is the stage 2 we are talking of. Stage 2, there is suppression burst episode, which is not pathognomic. This is not pathognomic, but it is a characteristic feature. So this is not particularly you say is pathognomic, but what we say, this is a characteristic feature and it is not pathognomic, which is same. So therefore, the most appropriate answer out of the choices given, which is particularly here, should be the CSF immunoglobulin G level. MRI of the temporal lobe is basically done for the mesial temporal sclerosis. Mesial temporal sclerosis, and this mesial temporal sclerosis can initially present as febrile seizure in a child. It can initially present as a febrile seizure in a child, but there is nothing to suggest that the child had the prior history of the febrile seizure, right? So this is regarding the question number 5. So the most likely the answer is the cerebrospinal fluid. You will go for the immunoglobulin G levels. Child with features of dehydration and ORS was given. Glucose will enter through which transporter? Although we see this question is something a kind of a bouncer which has come, because normally we teach is the composition of low osmolar ORS or the composition of rhizomol ORS, rehydration solution for the malnourished child, and suddenly a surprise question comes, how is the ORS absorbed? How is the ORS absorbed? And this is the lines I have taken. ORS is the key treatment of acute diarrhea in children, as it restores the electrolyte balance by stimulating the intestinal sodium glucose transporter 1 to induce the fluid absorption. So the answer here is the intestinal sodium glucose transporter 1, which induces the fluid absorption, right? So the right answer to this a simple question goes in favor of SGLT1, sodium glucose transporter 1. Again a so-called one-liner, simple question. Child with hypercholesterolemia, urine protein 3+ with fat bodies on microscopy. So you are being given here that there is presence of proteinuria, and this is a massive proteinuria because it is 3+, more likely in the range of nephrotic range. Then there you are being given there is hyperlipidemia, and finally it is also being given that there is lipiduria. There is lipiduria. So if all these three things are there, massive proteinuria, hyperlipidemia, lipiduria, it is most likely a case of nephrotic syndrome. Nephritic syndrome, hematuria is there, and never there will be massive proteinuria, right? So it is not likely nephritic, it is a direct one-liner type of question, and the question here is the nephrotic syndrome. Now, female is taking indomethacin since 25 weeks of pregnancy. What would be the situation of the baby during birth? And this is according to the recall that these are the choices given: patent ductus arteriosus, premature closure of ductus arteriosus, closure of fossa ovalis, premature closure of ductus venosus. Now, indomethacin broadly speaking can do two things. One, it can cause is the decreased urine output. If there is decreased urine output, it can cause oligohydroamnios. And if there is oligohydroamnios, it can lead to the pulmonary hypoplasia. Pulmonary hypoplasia. But there is nothing which is being given to suggest that this thing is there. And second thing it can cause is the premature closure of ductus arteriosus. It can cause is the premature closure of the ductus arteriosus. So if there is premature closure of the ductus arteriosus, that can be one of the thing. So most likely here the diagnosis is the premature closure of the ductus arteriosus. So answer should be the choice number B. Simple question, webbed neck, short stature, low posterior hairline, the diagnosis. Yes, webbing of the neck is particularly there. There is low posterior hairline which we are showing here. There is shield-like chest which is present here. The shield-like chest means there is hypoplastic nipples, flat chest, and this is a case of a Turner syndrome. So Turner syndrome 45XO, that is the Turner syndrome. And always remember, Turner syndrome incidence is not increased. Turner syndrome incidence is not increased with the increased maternal age. With the increased maternal age. Autosomal trisomies, you understand, there is an increased incidence, but here we say the incidence is not increased with the increased maternal age. Question number 10. Mother was worried about a 12-year-old child who was at short stature compared to the others. Again the same thing, webbing of the neck and the shield-like chest, and your diagnosis again go in favor of the Turner syndrome. And Turner syndrome, you all know there is presence of streak ovaries. That means the ovaries are only having the fibrous tissue, no ovarian follicle, and it is the most common cause of the primary amenorrhea. It is the most common cause of the primary amenorrhea. So this pelvic ultrasonography shows streak ovaries. That is the most likely answer. Maybe at the risk of mitral valve prolapse. It is a feature which is seen in the Klinefelter syndrome. It is a feature which is seen in the Klinefelter syndrome. Single kidney. Most likely if it is a problem here, you get is the horseshoe kidney. You get is a horseshoe kidney. So there can be plus skeletal features which are an important feature of the Turner syndrome, right? So these two questions, question number 9 and 10 based on the Turner syndromes, they were the direct questions. Now a 10-year-old child with upper limb hypertension, lower limbs loss of pulses and notching of the ribs, right? All the choices I could not get, but this is most likely what we say postductal coarctation of aorta. Postductal coarctation of aorta, right? You can yourself see if this is what we are showing here, and this is the aorta, and this aorta is having the coarctation. So in this portion there will be decreased blood supply. So what will happen in this portion where there is decreased blood supply? This will be supplying to the lower limbs, so there will be weak pulses in the lower limbs. And if you see particularly in the upper limbs, there will be more blood, so there will be upper limb bounding pulses. Moreover, normally in a person, the blood pressure is more in the upper limbs, normally in a person, the blood pressure is more in a lower limb as compared to upper limb, but in coarctation of aorta, the upper limb will be more than lower limb, the blood pressure, right? Then notching of the ribs, because if there is this coarctation, then there is some collateral circulation which develops, and there can be a collateral between the intercostal arteries, and the scapular branches of the subclavian artery, and this particularly supplies the abdomen. So there are two collaterals. One collateral is between the inferior epigastric artery and the internal mammary artery for the lower limb. Another is between the intercostal artery and the scapular branches of the subclavian artery. So if there is a collateral between the intercostal artery, the blood supply through the intercostal artery is increased, and intercostal artery is present along the lower border of the ribs, which causes is the notching of the ribs. Right? So these are some of the questions which were asked this time. There were other questions which are related to pellagra, related to pherinoderma, which can be integrated, right? So basically pediatrics is a very simple subject, and if you study, this is a highly scoring subjects, right? Thank you all. Do subscribe to the channel for the more updates. Thanks.